Hello and welcome. We will continue where we left in part 1. So, let's start. The learning objectives are shown. Please take a look. Vitamin D, a fat-soluble vitamin, is required for calcium absorption from gut. It can be synthesized in the skin from 7-dehydrocholesterol under the influence of ultraviolet light or absorbed from the diet in the natural form. Vitamin D3, cholecalciferol, or the plant form, vitamin D2, ergocalciferol. Active metabolites are formed in the liver, 25-hydroxyvitamin D or calcifediol, and kidney, 1,25-dihydroxyvitamin D or calcitriol plus other metabolites. Renal synthesis of active vitamin D metabolites is stimulated by PTH. The primary toxicity caused by chronic overdose with vitamin D or its active metabolites is hypercalcemia, hyperphosphatemia, and hypercholesteruria. The two forms of vitamin D, cholecalciferol and ergocalciferol, are available as oral supplements and are commonly added to dairy products and other foods. In patients with conditions that impair vitamin D activation, chronic kidney disease, liver disease, hypoparathyroidism, an active form of vitamin D such as calcitriol is required. 1-alpha-hydroxyvitamin D2, doxorcalciferol, is a prodrug that is converted in the liver to 1,25-dihydroxyvitamin D, whereas 19-nor-1,25-dihydroxyvitamin D2, paracalcitol, and calcipotriene, calcipotriol, are analogues of calcitriol. All cause less hypercalcemia and, in patients with normal renal function, less hypercholesteruria than calcitriol. Bisphosphonates is a group of drugs which are pyrophosphate analogues. Their mode of action is complex. They prevent dissolution of hydroxyapatite, which is the complex calcium and phosphate crystal found in the bone. They also inhibits osteoclast activity by interfering cholesterol metabolism. And we know that cholesterol is subsequently involved in prenylation of osteoclast proteins. What is prenylation? It is the addition of lipids to proteins to form lipoproteins within cells. And these lipoproteins may function as important cell surface and metabolic enzymes and targets. They also induce osteoclast apoptosis by forming suicidal forms of ATP. Bisphosphonates show high binding capacity for calcium. So no wonder, once you administer bisphosphonates, you would find them redistributed to bones, especially the sites within the bones where remodeling is active. Hence their action is blocked by calcitonin for obvious reasons. There are generations of bisphosphonates. The first generation or the early bisphosphonates was etidronate. The second generation were pamidronate and alidronate. And the third generation includes drugs like residronate and zoledronate. The potency of these generations is incremental. That means the third generation is much more potent than second generation, and second one is much more potent than first. Just recall that potency means ability to bring about a physiological action at a much lower dose. If given orally, should be given empty stomach with plenty of water because these drugs may cause esophagitis. They undergo renal clearance like many other drugs. Adverse reactions mainly include esophagitis. That's why they are given empty stomach in an upright position to facilitate rapid stomach emptying and with plenty of water to dilute the effects on esophagus and stomach. First generation may cause osteomalacia. Estrogens in females are quite well known to favor bone formation because they primarily increase the osteoblastic activity. Estrogens are prescribed in postmenopausal women as hormone replacement therapy. They stimulate all types of estrogen receptors, just like endogenous estrogens, for their favorable effects. But remember, there are side effects of estrogens as well. For example, thrombotic tendency and increased likelihood of breast and genital tract cancer. So long-term therapy with estrogen has to be taken into consideration. given these potentially life-threatening side effects. Estrogens primarily favor bone deposition by stimulating osteoblasts, thereby maintaining bone formation. They may also inhibit osteoclasts, but the major function is, of course, by virtue of their effects on osteoblasts. Take a closer look at this diagram and relate the mechanisms involved. There are two types of estrogen receptors, alpha and beta. Selective estrogen receptor modulators are the drugs which are given to circumvent and avoid the harmful effects of alpha receptor stimulation of estrogens. For bone mineralization, we need the activity of beta receptors, not alpha. So instead of estrogens, which will stimulate both receptors, it is quite beneficial and desirable that we may use drugs which just simulate beta receptors. And this is exactly what selective estrogen receptor modulators do. There are different drugs, such as tamoxifen, raloxifene, and tolera-fine. But we prefer raloxifene as compared to others, because they have minimal effects on uterine endometrium, because if you keep on stimulating uterine endometrium, there will be abnormal uterine bleeding and menstrual problems. So to avoid that, raloxifene is a good choice. The next group is RANKL inhibitors. A monoclonal antibody, denosumab, is used for this purpose as a RANKL inhibitor. RANKL is produced by osteoblasts to stimulate osteoplastogenesis. Remember, when there was induction and recruitment of osteoclasts, they would stimulate the recruitment of osteoblasts. And then osteoblasts would also, recruit more osteoclasts. It's a positive feedback loop. And this is how the bone remodeling unit is stimulated. They are given periodically, and there are no GI side effects, otherwise their efficacy is quite similar to bisphosphonates. So yes, they are quite costly, but they also lack the side effects commonly seen with bisphosphonates. Recall that osteoblasts are quite similar to macrophages, and if a drug inhibits the function of osteoblasts, it may also affect the function of macrophages. Thus, denosumab may interfere immune response. Now, this is something which is not seen with bisphosphonates, but it is seen with denosumab. So that is the downside. Recall that parathyroid hormone receptors are calcium sensitive. Now, calcium-sensing receptor agonists, such as cinacalcet, stimulate the parathyroid hormone receptors to induce the bone remodeling units, but also inhibits the parathyroid hormone secretion due to a negative feedback mechanism. It may cause GI upset and hypoparathyroidism because it inhibits the PTH secretion. Strontium is an alkaline earth metal and resembles calcium, being in the same group 2 of the periodic table. Being similar in properties, strontium is able to stimulate calcium-sensitive receptors and activate osteoblasts. It also favors osteoclast apoptosis. This table shows anti-resorptive drugs and parathyroid hormone compared in terms of their effects on bone architecture. Anti-resorptive drugs like bisphosphonate and calcitonin would reduce bone resorption, as well as reduce bone formation, because there's an overall inhibition. For new bone formation, it should undergo bone resorption first. So, over time, the mineralized bone gets stabilized and progression of osteoporosis stops. In contrast, spurts or episodic pulses of parathyroid hormone would favor bone resorption, but at the same time, they would also stimulate bone formation. So, yes, resorption stimulated, but bone formation would also be stimulated much more than that. And this will strengthen and correct the architectural problems seen in osteoporosis. Vitamin D and calcium supplements would help mineralize the newly formed bone. The glucocorticoids are a group of corticosteroid hormone analogs which are sometimes prescribed in a variety of diseases for long-term use, which leads to osteoporosis, because they prevent osteoclast apoptosis at one hand and induce apoptosis of osteoblasts on the other hand. So more bone resorption and less deposition. So, here is the summary of what we discussed in this lecture. Take a closer look. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!